do a quick introduction to Professor Ian Burwash. Ian is a great friend to me and as well as the St. Michael's Lab. I've known Ian for about 20 plus years. I had the privilege of actually serving as his vice president when we were volunteering for the CSE Canadian Society Echo. So Ian is a professor of medicine and director of the Echo Lab at the University of Ottawa Heart Institute. And just remember, we had the privilege of having Professor Kwan Chen, and also last week we have Professor David Mazika Zaitung. So they are all from the Ottawa Heart Institute. So it speaks to the caliber of the lab. Ian is actively involved in undergraduate and postgraduate teaching at the University of Ottawa and has mentored trainees in ECHO for more than 2 decades. He's a dedicated educator of primary care physicians, specialists, and sonographers nationally and internationally. He has served as imaging track captain for the Canadian Cardiovascular Congress, program chair for the annual meeting of the CSE, chair of the AFC subcommittee in adult echo for the Royal College of Physicians and Surgeons of Canada. He has also been the president of Canadian Society Echo. He has been the recipient of the Canadian Society Echo Annual Achievement Award and Distinguished Teacher and Mentor Award from the Canadian Cardiovascular Society. His clinical and research interests are focused on evaluation and management of patients with valvular heart disease. Especially speaking, I believe you were trained with Dr. Otto as well at some point, who was one of the guru in aortic stenosis. So without further ado, and Dr. Burwash.
Well, thanks a lot, Qiming.
Perfect.
Great. Well, first of all, I'd really like to thank you, Qiming, and really the whole echocardiography laboratory at St. Michael's Hospital for inviting me to present today. It's a real pleasure to have a chance to talk to you, so thank you very much. So what I'd like to do today is talk to you about when aortic stenosis evaluation by echocardiography is discordant, what additional echocardiographic measurements could be considered. And the objectives for the session today are certainly what I'd like you to be able to do at the end of this day is to identify the potential causes for discordant aortic stenosis on echocardiography, be able to discuss the role of stress echocardiography in patients with discordant aortic stenosis, and finally be able to recognize echo measures that are prognostically important in patients who have discordant aortic stenosis. Now, when we evaluate patients with aortic stenosis in the echo lab, often the diagnosis and management of the patient is very straightforward. Here we've got a 69-year-old woman who's got NYHA class 2 dyspnea. The velocity across this valve is 5.4 meters per second. The mean gradient is 82 millimeters of mercury, and the valve area is 0.46 square centimeters. All of these indices say that this patient has severe aortic stenosis, and this patient needs to have an aortic valve intervention. But sometimes the situation is a little less straightforward. Here we've got an 83-year-old man who has NYHA class 3 dyspnea. We can see that there's severe left ventricular systolic dysfunction. The ejection fraction is 18%. The velocity across the valve is 2.5 meters per second. The mean gradient is 14 millimeters of mercury, findings suggestive of just mild aortic stenosis. But the aortic valve area calculates at 0.78 square centimeters in the severe range. Does this patient have symptomatic severe aortic stenosis? Should we be intervening on this patient? Or here's another situation that I think you have all encountered in the echo lab, a 75-year-old woman with NYHA class 2 dyspnea. The left ventricular systolic function is normal. The ejection fraction is 70%. The velocity across the valve is 3.1 meters per second. The mean gradient is 23 millimeters of mercury, findings suggestive of mild to moderate aortic stenosis. But the valve area calculates at 0.63 square centimeters, suggestive of severe aortic stenosis. Are these symptoms due to severe aortic stenosis? Again, should we be intervening on this aortic valve? Well, I think we all know working in the echo lab that discordant indices as to the severity of aortic stenosis is very common during the evaluation of patients. And this is a study from minors looking at 3,500 echocardiograms that were performed in patients who had aortic stenosis and who had normal left ventricular function. And what they observed was that discordant indices as to the severity of the stenosis was present in 25 to 30% of the echocardiograms. The typical discrepancy being the situation where the valve area is in the severe range, but the peak flow velocity or the mean pressure gradient suggests that the stenosis is not severe. So why can these discrepancies occur where the valve area is in the severe range, but the velocity or mean gradient is in the non-severe range? Well, it can occur because of either technical reasons or it can occur because of physiologic reasons. From a technical standpoint, if we underestimate our left ventricular outflow tract velocity, perhaps our sample volume is too far from the aortic valve, or we're interrogating the left ventricular outflow tract from an oblique angle, or we underestimate our left ventricular outflow tract diameter measurement, this will result in us calculating a small, inaccurate aortic valve area, which then by the continuity equation will result in a small, inaccurate aortic valve area. So will be an inaccurate stroke volume leading to an inaccurate aortic valve area. It can also occur because we underestimate our aortic stenosis velocity. And if you think about it, if we underestimate our aortic stenosis velocity, that will result in an underestimation of the pressure gradient across the valve. Now, the underestimation in the aortic stenosis velocity will also lead to an increase in the aortic valve area. But because velocity has a squared relationship with pressure gradient, but a linear relationship with the aortic valve area, the drop in pressure gradient will be greater than the increase in aortic valve area and can lead to the situation of low gradient severe aortic stenosis. And there's an interesting study performed by the Mayo Clinic, which looked at which window was most likely to identify the highest velocity across the aortic valve, of which they found that was the right parasternal window. And what they did in the study is they said, hey, what would happen if we just interrogated the aortic valve from the apical window? In essence, they were underestimating the aortic stenosis velocity. And what they found was that in patients who they knew had severe high gradient aortic stenosis from interrogating all of the different windows, they found that 16% of these patients turned into moderate aortic stenosis, and another 10% of these patients turned into low gradient severe aortic stenosis. Well, what about some of the physiologic reasons why we can get discrepant data? Well, it can occur because the patient may have a small body size, and although the valve area is less than 1 square centimeter, it doesn't represent a severe stenosis in this small patient. And one of the ways we have to evaluate for that is we index the aortic valve area to the patient's body surface area. And if we see an indexed aortic valve area greater than 0.6 centimeters squared per meter squared, that suggests that this is just a small patient, and the valve area, although it's less than 1 square centimeter, doesn't represent severe aortic stenosis. It can also occur because there are inconsistencies in the definition of severe aortic stenosis in the valve guidelines. In essence, the valve guidelines say that an aortic valve area of 1 square centimeter should create a mean pressure gradient of 40 millimeters of mercury across the aortic valve, because those are the thresholds for severe aortic stenosis. But in actuality, if you take a valve area of 1 square centimeter and you take a patient with normal hemodynamics, so they've got a cardiac output of 6 liters per minute, a heart rate of 70 beats per minute, and a systolic ejection period of 330 milliseconds, you would actually calculate that a mean gradient of 1 square centimeter will only create a mean gradient of 34 millimeters of mercury, not 40 millimeters of mercury, as suggested in the guidelines. Another physiologic reason for the discrepancy occur because the patient's got a low flow state. And that can occur because the patient's got severe left ventricular systolic dysfunction. It can occur in patients who have mitral valve disease, significant mitral stenosis or mitral regurgitation. It can occur in patients who have significant tricuspid regurgitation, hypertension, pulmonary hypertension, and paradoxic low flow, low gradient aortic stenosis. Often those older, elderly women who have small, concentrically remodeled left ventricles, although their ejection fraction is normal because the diastolic volume of the ventricle is small, that leads to a small stroke volume. So how should we approach these patients who have low gradient severe aortic stenosis, valve area less than 1 square centimeter, velocity, mean gradient less than 4 meters per second, and 40 millimeters of mercury respectively? Well, the first thing you should think about, and really the commonest reason, is you're dealing with a situation of measurement error, and you need to confirm the stroke volume and aortic valve area measurements that you're using in your continuity equation. We can confirm our stroke volume measurement by performing Simpson's method, looking at the stroke volume by that technique, or ideally use 3D echocardiography and look at the stroke volume by that technique. This has the advantage. Sometimes Simpson's methods underestimates the stroke volume because you may be foreshortening your images. So 3D echocardiography is really preferred. You can also confirm your aortic valve area measurement. You can perform orifice planimetry and compare that to your continuity equation valve area. If on orifice planimetry you're getting a valve area that's much larger than what you're using in the continuity equation, again, it suggests that measurement error is the cause for the discrepancy. Now, if your data agrees well, you've got to start looking for other reasons. You've got to consider the patient's body size. Is the indexed aortic valve area greater than 0.6 centimeters squared per meter squared? If it is, it suggests this is a small patient. You're dealing with non-severe aortic stenosis, and that's why the velocity and mean gradient are low. If that's not the reason, you need to evaluate for a low flow state, which is being traditionally defined as a stroke volume index less than 35 mils per meter squared. If your stroke volume index is less than 35 mils per meter squared, you're dealing with the condition called low flow, low gradient severe aortic stenosis. If your stroke volume index is greater than 35 mils per meter squared, you're dealing with the situation of normal flow, low gradient severe aortic stenosis, or that situation where there's an inherent discrepancy in the definition of severe aortic stenosis in the valve guidelines. It's very important to distinguish these two entities because the prognosis of these patients is very different. In the situation of patients with preserved left ventricular ejection fractions, patients who have low flow, low gradient aortic stenosis have a much worse survival than patients who have normal flow, low gradient aortic stenosis, where the survival is more like moderate aortic stenosis, at least for the first 18 to 24 months after the diagnosis. Well, what about those patients who have low flow, low gradient aortic stenosis with a reduced ejection fraction, or what we refer to as classical low flow, low gradient aortic stenosis? Well, this is some of our data from the TOPAZ study, which is a registry of these patients. And we found that these patients have a very poor prognosis. If you look at the medical management of these patients, 50% of these patients are dead within 2 years. So a very poor prognosis. Now, while we use stroke volume index to define whether a patient has a low flow state or not, it's important to realize that stroke volume is not a flow rate. Stroke volume is a volume. If you want the flow rate, that is the stroke volume divided by the ejection time. And the transvalvular flow rate is actually a strong predictor of the prognosis of patients with aortic stenosis, and importantly is a critical factor in determining the implications of an aortic valve area less than 1 square centimeter. In this large study of over 1,100 patients who had moderate or severe aortic stenosis, what you see is that if their transvalvular flow rate was more than 242 mils per second, and this was the median value in the study population, the prognosis of these patients is much better than patients who had mean transvalvular flow rates below the median value of 242 mils per second. And importantly, an aortic valve area less than 1 square centimeter was only prognostically important in patients who had a mean flow rate above the median value, above 242 mils per second. And if you perform a sensitivity analysis, what you find is that the negative predictive value on outcome, or the negative implications on outcome in patients with aortic stenosis and a valve area less than 1 square centimeter, is present down to a flow rate of about 210 mils per second. But below that, there is a valve area less than 1 square centimeter is not prognostically important. Now, importantly in this study as well, if you look at patients who had normal flow aortic stenosis, defined as a stroke volume index more than 35 mils per square, millimeters of mercury per meter squared, a third of these patients actually had mean flow rates less than 210 mils per second. They actually had low flow rates despite that normal stroke volume index. And an aortic valve area less than 1 square centimeter is actually only prognostically important in these normal flow aortic stenosis patients if the mean flow rate was above 200 mils per second, not if the mean flow rate was below 210 mils per second. So why is it that an aortic valve area less than 1 square centimeter is not prognostically important in patients with low flow, low gradient severe aortic stenosis? Well, it's because not all of these patients actually have true severe aortic stenosis. Some of these patients have true severe aortic stenosis where they've got severe anatomic disease. But some of these patients have pseudo-severe aortic stenosis where there's only moderate anatomic disease, but the valve area calculates in the severe range because of low flow mediated forces being applied to open the valve leaflets. And depending on how you diagnose true and pseudo-severe aortic stenosis, whether it be by the valve weight when the valve is removed at the time of surgery, whether it be by valve calcification, whether it be by Dobutamine echo, or whether it be by surgical confirmation, about 2/3 of these patients have true severe aortic stenosis, and about 1/3 of these patients have pseudo-severe aortic stenosis. It's important to differentiate these two entities because the patients with true severe aortic stenosis are the ones you really want to intervene on. They're the ones who are likely to benefit from valve intervention. Whereas patients who have pseudo-severe aortic stenosis, they're unlikely to benefit from valve intervention because the valve is not the primary problem in their situation. And this was nicely shown in the TAVR Unload study, which looked at 178 patients who had moderate aortic stenosis and who had systolic heart failure. They were symptomatic and their ejection fraction was less than 50%. And these patients were randomized to TAVR or conservative therapy. These patients either had valve areas between 1 or 1.5 square centimeters, or they had valve areas that were less than 1 square centimeter at rest. But with dobutamine infusion, the valve area increased to more than 1 square centimeter. And what was found was that there was no difference in the hard endpoints between patients who underwent TAVR or patients who underwent conservative therapy. If you looked at all-cause mortality, no difference in the mortality rates between patients who were treated with TAVR or patients who were managed conservatively. And if you looked at major adverse cardiac or cardiovascular events, no difference in all-cause death, disabling stroke, heart failure related hospitalizations, or aortic valve related hospitalizations between these two therapies. So how do we distinguish true and pseudo-severe aortic stenosis? Well, according to the European Society of Cardiology valvular guidelines from 2025, if you have a velocity or mean gradient less than 4 meters per second, less than 40 millimeters of mercury, your valve area is less than 1 square centimeter, your stroke volume index is less than 35 mils per meter squared, and your ejection fraction is less than 50%, the guidelines say perform a dobutamine stress echocardiogram to distinguish these people, or look at an aortic valve calcium score. And the rationale is very simple behind the dobutamine echocardiogram. What you're attempting to do is increase the transvalvular flow rate and look at the valve hemodynamics at a more normal flow state. In patients who have true severe aortic stenosis, as you increase the flow through the valve area will not change and the mean gradient will rise. If a patient has pseudo-severe aortic stenosis, you increase the flow, there's more forces being applied to the valve leaflets, the valve area will get greater, and the mean gradient will change very little. And according to the European guidelines, they define true severe aortic stenosis as a valve area that remains less than 1 square centimeter, with a 20% increase in stroke volume during the dobutamine stress echocardiogram. Pseudo-severe aortic stenosis is when the valve area increases to more than 1 square centimeter with a 20% increase in stroke volume during the dobutamine stress echocardiogram. The AHA guidelines are a little bit different. They define true severe aortic stenosis when the velocity is more than 4 meters per second or the mean gradient is greater than 40 millimeters of mercury with a valve area less than 1 square centimeter at any time during the dobutamine stress echocardiogram. And they have no requirements for a flow response in their guidelines. Just a little bit about the dobutamine echo protocol. It's different than the protocol that we use for coronary artery disease. It's a much slower protocol, longer stages, usually 5 to 8 minutes in duration, and the dobutamine doses are lower, usually gradually increasing up from 5 to 20 micrograms per kilogram per minute. The protocol is designed not to induce ischemia, but just to increase the transvalvular flow rate. So here's a dobutamine echocardiogram in a 67-year-old woman who has NYHA class 3 heart failure. We could see that the patient has severe left ventricular dysfunction. With dobutamine, we can see a little bit of augmentation of the function around the basal lateral wall, the basal anterior wall. At rest, the mean gradient was 24 millimeters of mercury and the valve area was 0.7 square centimeters. With dobutamine infusion, the stroke volume increased from 46 to 56 mils, a 22% increase. The mean gradient went from 24 to 41 millimeters mercury, and the valve area increased to 0.71 square centimeters. According to the European guidelines, there's a 20% increase in stroke volume. The valve area is less than 1 square centimeter. This patient has true severe aortic stenosis. According to the AHA guidelines, we have a mean gradient of 40 millimeters mercury or more with a valve area less than 1 square centimeter. This patient has true severe aortic stenosis. Here's another patient, came through our lab, 68-year-old woman, NYHA class 3 dyspnea, has a past history of breast cancer treated with chemotherapy. Here with the dobutamine infusion, we see increased contractility. At rest, the mean gradient was 11. The valve area was 0.74 square centimeters. The stroke volume went from 37 to 50 mils, a 35% increase in stroke volume. Mean gradient changed very little, and the valve area increased to 1.14 square centimeters. According to the European guidelines, the stroke volume increased by more than 20%. The valve area is greater than 1 square centimeter. This patient has pseudo-severe aortic stenosis. And according to the American guidelines, there was never a point during the dobutamine echo where the mean gradient was greater than 40 millimeters mercury with a valve area less than 1 square centimeter. This patient also has pseudo-severe aortic stenosis. Now, unfortunately, this is the more typical situation that occurs when we do dobutamine echocardiograms on patients. A 76-year-old man, previous myocardial infarction, NYHA class 3 dyspnea. Here at rest, the mean gradient is 21 millimeters of mercury, valve area is 0.84 square centimeters. With dobutamine infusion, the stroke volume went from 55 to 58 mils, a 5% increase. Mean gradient went from 21 millimeters of mercury to 32 millimeters of mercury. Valve area went from 0.84 to 0.92 square centimeters. According to the European guidelines, this patient has indeterminate aortic stenosis because there was never a 20% increase in stroke volume. According to the American guidelines, this patient actually has pseudo-severe aortic stenosis because this patient never had a mean gradient of more than 40 millimeters of mercury with a valve area less than 1 square centimeter. Now, in actuality, with the dobutamine, although it appears that nothing much has happened, if you actually look at this transvalvular flow rate, you do see that we increased flow through the aortic valve. There was actually a 35% increase in flow rate, showing the problems of looking at stroke volume. And that explains why your mean gradient actually increased from 21 to 32 millimeters of mercury, because you actually increased the transvalvular flow rate. Now, the situation that we have here, though, is we still have discordant indices as to the severity, the mean gradient suggesting non-severe, the valve area suggesting severe aortic stenosis. But the problem is we never actually normalize the flow rate through the valve, which is about 250 mils per second. So what we can do, though, is we can harness this change in mean flow rate and the change in valve area with that change in flow rate to predict or project what would be our aortic valve area at a normal flow rate of 250 mils per second. So if we were to plot our aortic valve area at rest and our flow rate at rest, and we were to plot our aortic valve area at peak dobutamine dose with our flow rate, peak dobutamine dose, and we just extrapolate in a linear manner to a normal flow rate, we would project that the aortic valve area would be 0.93 square centimeters in the severe range, and that this patient has true severe aortic stenosis. Now, mathematically, this is just performed by taking your resting valve area and adding your aortic valve flow rate slope times the difference in flow from rest to 250 mils per second. So in our patient here, it's just that resting valve area, 0.84 square centimeters, plus the difference in valve area from rest to peak dobutamine dose, divided by the difference in flow from rest to peak dobutamine dose to slope, and then multiply that by the difference between the resting flow rate and 250 mils per second. Valve area 0.93 square centimeters, less than 1 square centimeters, suggesting true severe aortic stenosis. And we investigated this the accuracy of the projected aortic valve area at 250 mils per second in distinguishing patients with true and pseudo-severe aortic stenosis in 87 patients who had classic low-flow, low-gradient aortic stenosis. And we compared how it performed compared to the other proposed indices from dobutamine echo as to whether a patient has true and pseudo-severe aortic stenosis. And we compared it to either surgical confirmation in 62 patients or the aortic valve calcium scores in 25% of patients. And what we found was that the projected aortic valve area at 250 mils per second, whether it was greater than 1 square centimeter or less than 1 square centimeter, was the most accurate indice in distinguishing these two entities. And it had an accuracy of 70%. If you looked at the criteria from the AHA, where you need to have a mean gradient more than 40 millimeters of mercury with a valve area less than 1 square centimeter, the accuracy was only 47%. It was actually more likely to be wrong than right. And if you looked at the European Society of Cardiology guidelines, is the peak valve area more or less than 1 square centimeter? The accuracy was only 60%. Now, if you look at that 70% accuracy and you say, oh, that's not very good. This isn't a very good technique. It's important to realize there's just problems with the gold standard also. So if you look at, surgical confirmation, you can imagine there's some subjectivity to this, although we really tried to standardize things by, surgeons evaluating each leaflet and stiffness. And there's also problems with the aortic valve calcium scores. Remember, these scores were validated in patients who had concordant aortic stenosis, not in patients who had discordant aortic stenosis. And when we look at just actual surgical confirmation, we find that the projected aortic valve area correlates or has an accuracy of usually 90% or more compared to what the surgeon feels at the time of their evaluation. Now, probably what's really important is what's the prognostic ability of these indices. And if we looked at patients with projected aortic valve areas less than 1 square centimeter or greater than 1 square centimeter, and you look at just medically managed patients, patients who had projected valve areas less than 1 square centimeter had a much worse survival than patients who had projected aortic valve areas greater than 1 square centimeter. If you look at just looking at the is the mean gradient more than 40 millimeters mercury or less than 40 millimeters with dobutamine infusion? No difference in survival, looking at that index. And if you look at just the peak aortic valve area and the outcome, is it greater than 1 square centimeter or less than 1 square centimeter? There's a trend to a worse outcome in patients who had valve areas less than 1 square centimeter, but clearly the ability to discriminate patients is not as good as what you can obtain from the projected aortic valve area. And importantly, this is a study done by the Cleveland Clinic, 233 patients with classical low flow, low gradient aortic stenosis. If people had true severe aortic stenosis by the projected aortic valve area, less than 1 square centimeter, and you look at their outcome, medically managed patients, extremely poor outcome in these patients. On the other hand, if you took these patients and you operated on them, a much better survival. If you looked at patients who had pseudo-severe aortic stenosis, so their projected aortic valve areas were greater than 1 square centimeter, no difference in outcome if you manage those patients conservatively or you intervened on these patients. So it provides important prognostic information and helps guide you in your management of these patients. Well, is there other data from the dobutamine echocardiogram that can be useful in providing us, with prognostic information on these patients? And one measure that had been proposed in the past was the presence of contractile reserve, defined as an increase in stroke volume by 20% with dobutamine echo. And this is from the European Multicenter Registry in 136 patients with classical low flow, low gradient aortic stenosis. If the patients did not have contractile reserve, so if their stroke volume failed to increase by 20%, they observed an operative mortality rate of 32% in these patients. On the other hand, if the patient had contractile reserve, there was only a 5% operative mortality rate. And if you looked at the intermediate follow-up of these patients, if you had no contractile reserve, you underwent aortic valve replacement, survival at 3 years was only 38%. If you had contractile reserve with aortic valve replacement, 79% survival. Now, we did not find stroke volume, the change in stroke volume, to be helpful in risk stratifying patients in our TOPAZ registry. And similarly, a large study from the Cleveland Clinic of 235 patients with undergoing dobutamine echocardiograms with classical low flow, low gradient aortic stenosis, they also did not find the change in stroke volume to be helpful. In their study, If you looked at patients who were managed conservatively, no difference in survival in patients who had an increase in stroke volume of more than 20% or not. And if you looked at patients who underwent aortic valve replacement in their study, no difference in survival in patients who had contractile reserve or who did not have contractile reserve. So from my standpoint, I think this index really doesn't provide much value. Now, nowadays, though, most patients are being treated with TAVR. And again, this is some of our data from the Topaz TAVR trial, 193 patients undergoing TAVR, no difference in 30-day outcome, 1-year outcome, or 2-year outcome in patients who did or did not have an increase in stroke volume of 20% during dobutamine stress echocardiogram. So I think this index really is out of favor now and really doesn't provide us with any additional information. I think what is an index that may be of value is just looking at what is your peak ejection fraction with dobutamine infusion. From the Topaz study, we found that if the ejection fraction was more than 35% with dobutamine infusion, these patients had a better prognosis, a better survival. It seems to be restricted, though, really to the group of patients who are managed medically. When we looked at within the surgical group, we didn't find this to be of any value. But when we looked at medically treated patients, if you could increase your ejection fraction to 35% or more, you did have a better survival. Well, can we distinguish true and pseudo severe aortic stenosis just by looking at our resting hemodynamics? And the answer to that question is possibly by looking at the ratio of the mean gradient and the effective orifice area. In essence, what drop or what loss of pressure gradient across the valve occurs per 1 square centimeter of aortic valve area. If your ratio of mean gradient to effective orifice area is more than 25 millimeters of mercury per square centimeter, we found that this was 85% accurate in distinguishing true and pseudo-severe aortic stenosis as assessed by the projected aortic valve area during the dobutamine echocardiogram. And also, this index provides us with some prognostic information on the event-free survival of these patients. If the ratio is more than 25 millimeters of mercury per square centimeter, these patients have a worse event-free survival, either dying or needing valve replacement, compared to patients who have a ratio less than 25 millimeters of mercury per square centimeter. Well, what about this type of patient here, the patient who has low flow, low gradient, severe aortic stenosis with a preserved ejection fraction? Well, according to the European Society of Cardiology valve guidelines from last year, if your velocity or mean gradient are not in the severe range, but your valve area is in the severe range, your stroke volume index is less than 35 mils per meter squared, and your ejection fraction is normal, they suggest that these patients have an aortic valve calcium score to determine the severity of the stenosis. But in fact, dobutamine echocardiography can be helpful in these patients as well. And here is this patient. Mean gradient 23 millimeters of mercury, valve area was 0.57 square centimeters at rest. With dobutamine infusion, we can see that there's an improvement in left ventricular function. The stroke volume increased from 47 to 56 mils, a 19% increase, although the mean transvalvular flow rate increased by 58%. The mean gradient went from 23 to 40 millimeters of mercury. The valve area changed very little. And the projected aortic valve area at a flow rate of 250 mils per second was calculated at 0.69 square centimeters in the severe range. This patient's hemodynamics are consistent with a severe aortic stenosis. And the projected aortic valve area has been tested in patients who have low flow, low gradient severe aortic stenosis with a preserved ejection fraction. This is a study looked at 55 patients who had both a combination of actually exercise echo and dobutamine stress echocardiography. And what was found in this study was that if your projected aortic valve area was less than 1 square centimeter and the patients went on and had surgery, that was 94% accurate in distinguishing true and pseudo severe aortic stenosis. And again, importantly, it's also a strong predictor of the prognosis of these patients. Patients who have projected aortic valve areas of less than 1 square centimeter in this population have a much worse event-free survival. They're more likely to develop symptoms and need valve replacement or die as compared to patients who had projected aortic valve areas greater than 1 square centimeter. Another important index in patients with low flow, low gradient aortic stenosis with a preserved ejection fraction is the dimensionless index. Patients who have a dimensionless index less than 0.25, so that ratio of the LVOT velocity to the AS velocity, if you have a ratio less than 0.25, you have a much worse prognosis than patients who have low flow, low gradient aortic stenosis with a dimensionless index greater than 0.25. These patients tend to have a prognosis more like those of normal flow, low gradient aortic stenosis, which is a little more of a, a benign prognosis, more like moderate aortic stenosis. Well, here's another patient who came through our echo lab, 84-year-old woman who had NYHA class 2 exertional dyspnea. We see the left ventricular function is normal. Velocity across the valve 3.6 meters per second. Mean gradient's 31 millimeters mercury, suggestive of moderate aortic stenosis, but the valve area is 0.88 square centimeters. This patient came through our stress lab and had a dobutamine echocardiogram performed. And what you could see was that the stroke volume actually fell with dobutamine, went from 70 to 66 mils. The mean gradient went from 31 millimeters of mercury to 49 millimeters of mercury. The valve area went from 0.88 square centimeters to 1.16 square centimeters. So looking at this data, how would you report this stress echocardiogram? Would you say it's indeterminate because the stroke volume didn't increase by 20%? Would you say this person's got true severe aortic stenosis because, wow, that gradient's 49 millimeters of mercury? Would you say this patient has pseudo-severe aortic stenosis because the valve area is more than 1 square centimeter? Well, I think it's important when we see these patients, we think a lot about them. This stroke volume is 70 mils. For this patient, the stroke volume index is 39 mils per meter squared. This patient has normal flow, low gradient aortic stenosis. And according to the European guidelines, velocity and mean gradient are less than 4 meters per second, less than 40 millimeters mercury, valve area in the severe range, stroke volume index greater than 35 mils per meter squared. The guidelines say this patient has normal flow, low gradient aortic stenosis. Severe aortic stenosis is less likely. Tells us nothing what to do. What's important, though, to remember, as we talked about earlier, is that about a third of patients who have normal flow, low gradient aortic stenosis by their stroke volume index actually have a low flow state. Now, the mean flow rate across the valve in this patient is 252 mils per second. It's actually normal. And you can see with the dobutamine, we massively increase the mean flow rate through the valve. We have this a super normal response, 66% increase in flow rate, which explains why the gradient, markedly increased. And also with the increased forces from the increased flow caused the valve area to increase. Now, if you believe in the concept of the projected aortic valve area, where the valve area at a normal flow rate, 250 mils per second, accurately evaluates the severity of the stenosis, you would say this person at a flow rate, a normal flow rate is 0.88. This person has severe aortic stenosis. In fact, there's an interesting study that's looked at, is exercise or dobutamine echo necessary in all patients, in this case, in patients who had severe low flow, low gradient aortic stenosis. They looked at 67 patients. They were a combination of classic low flow, low gradient aortic stenosis, valve areas less than 1, mean gradient less than 40 millimeters of mercury, ejection fraction less than 50%. And they also included patients who had paradoxic low flow, low gradient aortic stenosis, normal ejection fraction, stroke volume index less than 35 mils per meter squared. All of these patients had a stress echocardiogram done, and they used the AHA criteria for true severe aortic stenosis. And what they observed was that if your mean flow rate was more than 200 mils per second at rest in these patients, so you're approaching normal flow rates, 84% of these patients would, on the dobutamine echocardiogram, be found to have true severe aortic stenosis. In essence, the aortic valve area at a normal flow rate accurately reflects the severity of the stenosis. So in our patient, the valve area of 0.88 square centimeters at a normal flow rate accurately reflects the severity of the stenosis. This patient has true severe aortic stenosis. Now, this patient did have some corroborating data. This patient also had an aortic valve calcium score performed, and just for your interest, this was about 1,650, which is consistent in a woman with having severe aortic stenosis. So the last discrepancy I'd just like to talk about is this type of situation. 62-year-old man, NYHA class 2 dyspnea. Velocity across the valve, 4.4 meters per second. Mean gradient, 46 millimeters mercury. Findings suggestive of severe aortic stenosis, but the valve area is 1.2 square centimeters. Findings suggestive of moderate aortic stenosis. Is this person's symptoms due to severe aortic stenosis? Should we be intervening on this patient? Well, our approach to these patients, first thing, we need to consider measurement error. In these patients, very important to evaluate that aortic stenosis velocity, make sure that it hasn't been overtraced and that you're into the fine filaments. And you need to confirm your stroke volume and aortic valve area measurements by continuity equation. Compare it to stroke volume by other techniques, 3D echo, compare it to the aortic valve area by planimetry. If you're, by these other techniques, you're getting smaller stroke volumes and you're getting smaller aortic valve areas, using planimetry, then what you're seeing with your continuity equation, you're probably dealing with severe aortic stenosis. If your data agrees, the next step is to consider the patient's body size. Maybe this is a large patient. Look at your indexed aortic valve area. If your indexed aortic valve area is less than 0.6 centimeters squared per meter squared, although the valve area is more than 1 square centimeter, it represents severe aortic stenosis in this patient. If that is not present, you need to consider, is there significant aortic regurgitation present? Maybe you're dealing with a situation of mixed aortic valve disease, both moderate stenosis and moderate aortic regurgitation. If there isn't significant aortic regurgitation, think about a high flow state, which is a stroke volume index of 55 mils per meter squared. If you do see a high flow state, it suggests moderate aortic stenosis, and, you need to look for reversible causes for the high gradient. Think about things like anemia or hyperthyroidism. What we do know about patients who have high gradient moderate aortic stenosis is that the prognosis of these patients is very similar to patients who have high gradient concordant aortic stenosis. They've got similar NT-proBNP levels, they've got similar aortic valve calcium scores, and it's actually the mean gradient or the velocity, not the valve area, which is predictive of the outcome of these patients. And according to the European guidelines, they would say if you've got a severe velocity or mean gradient and your valve area, though, is more than 1 square centimeter, if you don't have a reversible reason for a high flow state, you should consider these patients as having severe aortic stenosis and manage them like that. And our data here would certainly agree with that approach. So just to conclude for you here, discordant indices of aortic stenosis severity are very common. We in the echo lab, we see classic low flow, low gradient severe aortic stenosis with a reduced ejection fraction. We've got paradoxic low flow, low gradient severe aortic stenosis with a preserved ejection fraction. We've got normal flow, low gradient severe aortic stenosis, and we've got high gradient moderate aortic stenosis. When you see these discrepancies, it's very important to explain why there's a discrepancy. Make sure you rule out measurement error as the reason. It's really important to consider the transvalvular flow rate, not just the stroke volume index in these people. Dobutamine stress echo is recommended in patients who have classic low flow, low gradient severe aortic stenosis. And I would emphasize that it can also be helpful in patients who have paradoxic low flow, low gradient severe aortic stenosis, both in determining the severity of the stenosis and providing prognostic information. And finally, you should consider additional complementary echo measurements, such as the ratio of the mean gradient to the EOA ratio in patients who have classic low flow, low gradient severe aortic stenosis, in patients who, in patients with paradoxic low flow, low gradient severe aortic stenosis, consider the dimensionless index, because this information can be helpful in risk stratifying these patients. So I'd like to finish here and thank you very much for your attention. I'd be happy to answer any questions.
So thank you so much, Ian, for sharing with us this presentation. I have to admit, I've listened to your presentation over many years, and every single time I hear it, I learn something, and then also remind me of things that I should remember. And I'm so glad that you allow us to record this. I'm sure I'll watch it over and over again, and whenever I come across one of these cases, just to refresh our minds. So thank you, and it's open for questions and discussion. Any questions from the audience? And by the way, just to mention that at the peak, we have close to 90 online participants this morning. So we're like more than 120 people listen to your presentation this morning, all groups actually. So feel free to put in your questions in the chat or.
Yep. Just looking at a question here. Yep. Curious, how often don't you do a CT calcium score in these patients? Yeah, it's a interesting situation. Obviously, we've got access to both of these techniques. And, I would say in the majority of the time, we do both tests. And that can lead to often some discrepancies. One says one thing and one says the other. And in that type of situation, you've got to make a decision, which data do you think that it's the best data? Aortic valve calcium scores, you can just imagine situations where there's problems. I mean, in an echo lab, you can see one cusp that's just loaded with calcium that just bumps up the score, yet the other cusps don't look too bad. I must say I'm maybe biased. I like echocardiographic data because it's your hemodynamic data. It's and to me, hemodynamic data trumps anatomic data. When the two agree, great. When they disagree, you've just got to kind of make that decision on which data you think is the best. I think we've got a lot of data, on the prognosis of patients based on, things like the projected aortic valve area. So I very much lean a little bit towards echo data when it's good echo data, and I think we all have that kind of ability to, what's good data and what's not good data.
Any other questions from the audience? So maybe I'll ask another one myself. And so how's TAVR actually change all this? Because I've been hearing about this for the last 25 years, and thanks to all your work, and really sort of become you became our go-to person in aortic stenosis in the country, and also put Canada on the map regarding aortic stenosis. So how does TAVR actually change all this? Does it really matter about any more about these low gradient, classic versus paradoxical, and or or the diagnosis become less important. That's actually even more important that we have to identify these patients.
Yeah, I think, I mean, there was definitely a move saying, hey, there was a lot of observational data saying that a moderate aortic stenosis, it's got a really bad prognosis. We should intervene on these people. And, there was a lot of observational data showing that. And in that situation, people were very much, oh, who cares? Let's just intervene on the valve and not worry about the subtleties. But I think the TAVR unload trial is really said, whoa, just a moment here. There is no benefit to doing a TAVR on these people, and there is a risk to doing a TAVR. In the TAVR unload trial, again, there was no difference in outcome compared to surgical management. In that study, though, there was a TAVR patient who had a disabling stroke. When if you say, geez, would you like to have a stroke, but there's no benefit to us, waiting and doing this later? I think the patient would perhaps say, well, maybe let's not do it now. The other thing about the TAVR unload trial is, in that trial, there was no mortality rate occurring with TAVR. I don't know if your place runs the same way, but we don't have a 0% mortality rate with a TAVR intervention here. So they got away in their trial. They didn't have a death, but we certainly don't achieve those results here in Ottawa.
Often they are the sickest bunch in the group in terms of when we do TAVR. And how about operating on the severe AS asymptomatic patients? Because that's another huge discussion moving in the last couple of years.
Yes. So I can tell you I continue to manage these patients conservatively. Now, when people get into the very severe range, you're seeing, peak gradients or peak velocities across the valve of over 5 meters per second. I will intervene on those patients. But for the patients who, have severe aortic stenosis, less than that, who I'm able to follow, I continue to take a conservative approach in those in those patients. If there's very unique situations, maybe a patient is unable to be followed closely, I think that's a different situation. But I currently do not intervene on those patients. I think stress testing is valuable in these patients. How well do they perform there? I definitely use a lot of stress testing in the evaluation of these people. I don't use stress echocardiography. There was some data suggesting that, if your mean gradient increases by more than 18, 20 millimeters mercury with exercise, that's maybe a higher risk group. I haven't found that to be particularly helpful. So I follow them conservatively. I use stress testing in those situations, but I'm not using echocardiography, stress echocardiography. I would say in our group here in Ottawa, most of the people have not bought into the intervening on the severe asymptomatic person. By far, the majority of people are continuing with conservative management of these patients.
I would say same here. And but